Next we have probably one of the most versatile surgeons, eye surgeons in India, who is really good with VR surgery, and absolutely his anterior segment surgery is an art. I mean, for this session, I've asked him to concentrate on the anterior segment part of it. He'll be talking on two topics. The intraoperative rock hard eye. I mean, the eye becomes rock hard during surgery. There can be a few reasons for that, and when the nucleus doesn't rotate, what should you go for? Dr. PRABHU Shankar.
Thanks, Srini. So I'll just go into the first video. What happens now after the phaco surgery? And once you decide after the cortical wash, you can see the chamber shallowing up and PC pushing up, bulging up and eye. So what happens is now after the cortical wash, you can see, all the viscolectus is coming out. You try to open the main section, the iris is coming out. So you know that something is wrong in the globe. You shouldn't attempt further. So every time I just try to push the iris, it's just coming out through the section. So I'm just trying to repose it from the side, and some temporal cortex is already left because the PC was bulging and I didn't do an AC wash. So in this scenario, what I do is I just aim, glow is pretty good. So that's important feature, red glow is good. So 3 millimeters from behind the limbus, I either go with a 24 or 26 gauge needle. I just go right behind the posterior capsule. What happens is the fluid gets locked. During phaco, the fluid gets locked in the burger space. So between the anterior hyaloid and the posterior capsule, the fluid gets locked. So PC tends to bulge up. So now what I'm doing is I'm just gently going out. You can see the needle under the posterior capsule. So I gently aspirate. You can see the eye collapsing slowly. So now you can see the folds in the PC now. That means the PC is going back, and even the cornea, there's some quite few folds. So that shows that some hypertony is there. So now I go inside, put in the visco. So now we have quite a deep anterior chamber. So and now we can proceed with your IOL implantation. So now it's comfortable. So whenever the iris is prolapsing post-phaco, post-cortical wash, your iris is prolapsing and the PC is bulging, never attempt to put a IOL because 100% you're going to end up with a PC rupture and anterior vitrectomy. So in this case went on smoothly because the chamber became very deep and the posterior capsule also went behind. Next.
Prabhu, see, there are a few. This is done on intraoperative.
Yeah, two more videos.
Okay.
Yeah, this is another one. This is another patient with again a positive pressure post phaco. So only thing here we have to just see look at that episcleral vessels. They're all dilated. So this is one clue. I'll tell you what happened. So and now I decided okay, I'll again attempt with 25 gauge needle. So usually you need to go around. You should also try with the 26 gauge needle also can be right, but the 24 gauge needle it's quite easy to aspirate that liquefied fluid. So what happens is I just go behind and try to aspirate, and in this condition nothing happens actually. Neither the fluid gets tapped from the anterior hyaloid, the PC is still bulging, there's no change, and even after this maneuver, so once the eye is still pretty hard and nothing is happening. The small hemorrhage there near that area where. So once the PC was bulging, so you can see the iris that's stuck to the wound there. So there's no hypertony at all there. This positive pressure is still there. In this case, I decided not to proceed further. So what I did is after the anyway patient just closed up the case and asked one more of my VR consultant to have a look. And what they said is patients had a suprachoroidal, aborted suprachoroidal. There's one danger we should all keep in mind. So once you attempt tap from the anterior hyaloid and nothing's happening, make sure you don't proceed because there's always a chance, in spite of a good red glow, patient had aborted suprachoroidal hemorrhage. So there's another patient during cortical wash, you can see the PC bulging up and very difficult. In this case, you'll have to be very careful because the minute the smallest mistake you do and once the PC gets ruptured, then you'll have to again do extensive anterior vitrectomy, cortical cleanup and everything. And here somehow managed it to do gently. And once you finish the eye, you can see the iris getting stuck there. So again, in this case, is another video where I tapped it from the temporal quadrant. So another thing, I think what Umesh was saying is they just put a trocar candle, 23 gauge or 25 gauge trocar candle, 3 mm behind the limbus, and that just keep it open, that fluid gets trapped off. So instead of putting the needle, only thing we should have that say instrument set ready.
The advantage of putting just a one trocar cannula would be that you are not aspirating.
Yeah.
See, if you look at the pathophysiology here, it is the high fluidics or the saline that goes behind into the burger space, and you just need to remove that fluid. That's all. So when you put a trocar cannula and just leave it, there is no aspiration happening. Probably the fluid, once it comes out, then you can go ahead.
Only thing you should have to use the non-valve cannulas.
Yeah.
If you use the valve cannulas, then nothing's going to happen. You have the non-valve
See,
cannula.
if you have actually tried to attempt vitreous tap in endophthalmitis with a 26G needle, nothing comes out.
Yeah, yeah. That's right.
So the traction, so if it is a 30G needle, it'll be much better. But the best to use, I mean, if you have a small gauge vitrectomy cutter, you can just go with it and aspirate there. But second video, so that's what I wanted to discuss in the beginning. Say before you actually aspirate it, you have to make sure. See, I'm not really worried about 26G needle or 30G needle causing traction and causing breaks. No, probably it won't happen. But the thing is, this whatever is happening could be because of an expulsive end process.
That's what.
See, so before putting the needle in, I would always ask. See, I mean, we have a long OT, and not so. Ask our retina colleague to see if it is that, then nothing. Leave it there and plan everything. So if it is not there, give IV mannitol. See, before trying, because it has happened to me at least 7-8 times. So only after seeing your thing, I've attempted it twice.
This special condition, IV mannitol doesn't work.
No.
The fluid gets locked there.
No.
IV mannitol, you shouldn't actually.
It works. See what mannitol does. It causes shrinkage of at least a little bit. Shrinkage of the vitreous. That's what. See, any shallow anterior chamber surgery, a crowded anterior chamber, what is advised is 100 ml or 200 ml mannitol half an hour to 1 hour before the surgery, because that helps. Here also it is going to help, and it might not be that easy. So in one case, I in fact had postponed the case for about 2 weeks, and I took it. So if you are actually sure that there is no expulsive, yes, you can do all these procedures.
That's why I showed both the videos.
Yeah. So that's it. Gopal, your opinion on in this aspirating, because the aspiration is happening. This is a fluid that goes through the zonules into the Berger space, which is a potential space between the anterior haloid phase and the posterior capsule. So you, whatever comes out easily is just the fluid. It's not the vitreous. you're not going to keep on trying to aspirate and all. It just comes out easily. So your comment on this thing.
What I would like to say is, if it is a young patient, you put a needle into the vitreous, it will induce a PVD. You don't have to aspirate. If it is an older patient, 60 plus, already PVD is there, then even if you aspirate some fluid, nothing is going to happen. So in a young patient, we need to be very careful. A young patient or the patient in whom PVD is not yet there, you put in a needle, definitely PVD will be induced. There are studies that an uncomplicated phacoemulsification in a patient who did not have a PVD induces PVD in about 50% of people in the next 3 months. So induction of an unnatural PVD definitely brings in tears in the periphery. So I think the world is going towards a lower age for cataract surgery. So I don't think we should generalize like that. Your theory is very well taken. It's a fluid which you're aspirating. But in a younger patient, be careful. That's all.
Yeah, this is a process for which Boris Maligan won the best video award. See how this happens. It's called
Fluid
acute
misdirection.
acute
Fluid
intraoperative
misdirection.
rock hard eye syndrome, AIRES. So he showed the video on how this happens. See, like during cataract surgery itself, you might sometimes post-operatively you might sometimes see some cortical particle sort of things floating around in the anterior vitreous. You don't understand why this has happened. See, these are things that have gone through the zonules into the anterior vitreous area. So he actually demonstrate how it happens, and he got the best video award. And now, Prabhu, you have anything? Oh, okay, and the next presentation by Dr. Prabhu is on how to manage. See, if you have a non-rotating nucleus, what next? Yeah,
Can I have a short comment, sir?
yeah, please,
Yeah.
Kaushik, please.
So in acute intraoperative hard eye, I think one should also ask, I'm Dr. Swati Agrawal from Kolkata. So I think one should also ask the patient to, loosen the speculum, ask the patient to breathe in through the mouth, and then do a sterile IO first, which is a must, I guess, before inducing further hypertony. And if it doesn't work, we can shift the patient to the ward, wait for the mannitol to take its full effect, and a vitreous tap can also be done, or alternatively a pars plana aspiration with a vitreous. We can
Small
tap,
gauge vitreous
yeah,
cataract.
with the buds or any spatula, we can tap at the globe and see whether there's no hypotony. So hypotony should never be induced, and thereafter we can proceed. So I had this case where the cornea turned white and waited for 1.5 hours, 90 minutes, and then took up the case. Again, I displaced the viscoelastics from under the iris from the opposite port. So, sometimes viscoelastics can get trapped, and that again further induces. So, some prophylactic measures needs to be taken. Thank you, sir.
Thank you. Prabhu.
It's a small pupil with brown cataract, so always safer to put the retractors first, and you can always stain whenever you want. Restain the make sure, especially in brown cataracts, you get a good capsular access, because especially hard cataracts, if the rexus goes wrong, your surgery is going wrong. So very hard cataract, I have not done a hydrodissection yet because there's hardly any space there. So once going through a vertical chop or 2 millimeters, initially once you get the first chop in and you get a small chop, it's very difficult to rotate the nucleus because there are a lot of capsular cortical adhesions there, nucleus never rotates. See, when I'm trying to manipulate, nothing happens. So always in a brown cataract, if you're not able to rotate anything, make sure the first small triangular piece of nucleus is removed from one edge or a central core is removed. Once the space is created, the fluid starts moving around inside the bag, and then next step, the nucleus nicely rotates. So only thing but only thing is when you do, if your hydro has gone through and then your nucleus not rotating, then always keep in mind posterior capsular dehiscence. If your hydro is through, if you're not done hydro, then you're pretty sure that the PC is not opened up, then you can do all the maneuvers. So always be careful when non-rotating nucleus is there during your procedure always think of posterior capsular rent and make sure that you don't drop the nucleus during your procedure. So after that, only thing is, see, even in spite of nucleus rotating, we're not able to get at it at all. So sometimes you have to bring that one of the edges out, hold it, and get the triangular bit of nucleus out of the bag and create a maneuver. So then you can always use the second instrument and get the nucleus out. Srini, any point on brown cataract? Srini, anything in brown?
See, on the first point, why didn't you do hydro in the first place?
I don't do actually in a very hard brown cataract because hardly any space is there, no? And you get a hydro through a first run, nothing happens actually. So especially in brown grade 4 cataracts, I don't do hydro. You get the trench in, get the first chop, get a triangular piece out, then the nucleus starts moving. Because I'm sure that I've not opened the PC.
Yeah. Especially in women, the PC is so thin. Especially in women, the PC is so thin that you do the hydro like the way that you do for the other cases where you want to see the fluid wave and all. If you do that, you might find the nucleus in the vitreous, even if there is no posterior polar cataract. Any comments?
I think without doing hydro also you can loosen up the nucleus, and that is a simple procedure. We can just rotate, half rotate or quarter rotate. That itself will take care of most of the thing. Probably the non-rotation in a hard cataract, most of us will follow, will see at some point of time. And when you see that, some of these tips and tricks will always work. I think the removal of one quarter, what it essentially does is it debulks the whole bag. Then you have enough space to maneuver, and that helps you to further rotate more with more peace, because you're always concerned that when you do excessive rotation you can drag the bag or the lens. So once one piece is out, when you have space, maneuverability become easy.
So the rotation is attempted only after removing a pie, right?
First stretch, yeah.
Yeah.
Chop.
Okay.
This is another video. You see, already the posterior capsule is opened up completely. So in this case, you cannot do a hydro, cannot do rotate the nucleus. So what you have to do, just slowly debulk the nucleus from all the quadrants, and finally from one pole you have to lift up and slowly, since it's a soft cataract, relatively easy. And maneuver should be very gentle. You can see the posterior capsule opened up behind, and since it's a soft cataracts, you can just gently aspirate it, and make sure before the last quadrant is aspirated, you come out to inject visco, deepen the chamber, and then remove the last fragment, because the PC just bulges up, and again the vitreous also will come out. So in this position, I'm just holding on now. I'm just putting the visco through the side port. So stabilize the chamber, stabilize the bag. You can see the posterior capsule completely opened up there. Then aspirate the last fragment. So hardly any movement in the anterior chamber, and the nucleus with the cortical matter comes out. Now everything is stable now. The only thing is these conditions, you'll always make sure you never decompress the bag or the anterior chamber, because the vitreous can come out. I'm placing the IOL into the bag now. So the posterior capsule is already opened up. So this same non-hydro technique is always safer for any type of posterior polar cataracts. So once, or the other option is to do hydro delineation. In this case, you cannot do it because the capsule is already opened. So any posterior polar cataract, never do hydro dissection. Either delineate or go for a no hydro phaco. That's the safest procedure. Srini, posterior polar.
Yeah, I feel. See, nowadays I'm doing no hydro phaco for all posterior polar cataracts.
You can
All,
make it, you have time.
even the softest, because see, even when you do a hydro delineation, there can be a breakthrough, and it can cause. See, what is happening? The intracapsular pressure increases, and see this is absolutely brilliant surgery here. the PC is already open. See, there are when you see some word like this, see the two types that you see of a posterior polar cataract. One is if you see that word there, uh, uh, you get after at the end of phaco. At the end of phaco, you see that pseudo hole there in the posterior capsule. See, those cases are absolutely fine. Like if you're careful and you're not again keeping on polishing or not, they'll be good. But it's those posterior polar cataracts where you have uh, sort of deposits at the center of the posterior capsule, and you feel okay, everything is fine, everything went off fine, and you're going to polish that part with whatever you're doing. The PC is going to
No,
open up
that's
there
what in posterior polar cataracts, you should expect the PC rent any time. Because
anytime,
I had
even
it during
and
IOL aspirate,
after
cortical
after IOL
aspiration,
implantation
IOL
also.
implantation. Even I've seen the PC opening up when I'm closing up.
Yes, yes. So
So the
this
smallest of
happens.
mistake you make, your PC is going to open.
Exactly.
So never do PC polishing.
like all those things are there. You need hydro procedures for phacoemulsification. You don't need hydro procedures for phacoemulsification. So doing a wonderful cortical cleaving hydro reduces the amount of cortex that you have to aspirate. But you try phacoemulsification without hydro, it works. So in these cases of posterior polar cataract, I don't do any hydro procedure at all. They say, okay, why don't you do visco dissect the anterior capsule from the lens matter? It doesn't matter. What matters is how you take care of the posterior part. So it rotates. Uh, you initiate the phaco. Initiate the phaco. If it is NS3, 4 and all, then do the dissection. Once you do the division, chop and divide. Once you do the division, all these additions break up and you can easily rotate. Very soft ones are the ones that you might not be able to rotate many times, but you will be able to aspirate. So that is what I go for in posterior polar cataract these days. And
This is the last video.
I'll send my the first paper for Dr. Vanathy. It's already ready. So I'll send it.
Yeah, this is another one with subluxated lens. I'm putting in a CTR. So PXF is there, subluxated lens. Once the CTR is in, you can see the temporal zone. You can always see the edge of the lens there. So in this case, so then slowly I start the phaco now. So since the entire bag is moving, so after my first trench, I'm not able to rotate the nucleus at all. You can see the chamber depending, the lens going much behind. I get the chop done and hardly any movement is there. So again, I try to create that triangular bit of nucleus out and get the first small bit out to create space, but hardly the nucleus is moving. You can see, the lens jumping inside because of the subluxation. Some of that nasal quadrant of the nucleus I'm able to remove, but the temporal part gets stuck there. So there's hardly any movement of the nucleus inside the bag. So subluxated lens is always better to put the CTR right in the beginning of the surgery. So only thing, hydro will be very difficult. Hydro dissection will not go through. But anyway, the chamber will be stable and the nucleus will be stable. So now again, I'm trying to put two dialers and trying to rotate. Nothing's happening there because the temporal zonules are very weak. There's hardly any movement there. Some minimal movement is there. Then I just see nothing's happening. So somehow I just try to get half of the nucleus out. Now you can see the bag moving a lot inside the eye now. So I'm just trying to get a hold of the nucleus in some edge, at least try to debulk it as far as possible. Only thing is all these surgeries, in the beginning, if you know it's already subluxated, better they block these patients because you don't know how long this procedure is going to prolong. All subluxated and nucleuses. You can see the lens wobbling inside. There's too much of movement. So this is the time I decided, okay, put in the
Yeah,
capsular
this is
hooks
what I
there.
wanted to ask.
Put in the capsular hooks for the last quadrant I do it. So put two capsular iris hooks. I hook the capsule instead of the iris, and now things stabilize now. So whenever you have a zonular dialysis, always put a capsular hook in that particular quadrant, and things are very stable now. See, I'm ridiculous rotating. The surgery goes very smoothly now. The pupil has come down a bit from that full dilated position to around 4 to 5 millimeters. But since things are so stable now, since the capsules are hooked up, there's hardly any movement. I'm able to comfortably complete the phaco. And once you put in your lens, you can always remove all those retractors, and things are very stable now.
You put an iris hook or a capsule hook?
Yeah. So I've hooked
Prabhu?
the capsule actually.
Yeah.
So things are very stable now.
It's an iris hook like once.
Same iris hook, I just hooked the capsule.
Yeah.
Not that capsular hooks,
Yeah.
the same iris hooks. Which
The advantage with capsular hooks is it protects the equator. But now that the CTR is in place, it's okay. Iris is okay because if you do it with
But only
just the
thing
iris
is, we
hooks,
don't know all these grossly subluxated lens, how long they're going to stay. Okay, I've seen my own patients after 5 years, 6 years coming down with dislocation.
yeah, that depends on the pathology that has caused the thing. If it is a traumatic subluxation, it doesn't progress. If it is something like pseudo exfoliation, you will find the whole capsule
Back
IOL
dislocating up.
CTR complex in the vitreous after some time. It'll be there. So
That is why most of us now prefer putting the three-piece sensor because even when it goes, we do internal fixation and can do a MNS technique so that no need to remove it. So that is one technique that we are doing where you know that there is subluxation in future, you anticipate it is going to drop or whatever. You put a sensor three-piece. And
no, the technique advice is put it in the sulcus and capture.
no,
Capture
even
it.
otherwise, once the zonules are there, progressive zonular weakness, at some point.
It gets stuck to the. It's there in the sulcus. For a little bit of support and for centration, you capture it in the.
Thanks,
so,
Srini.
thank you, Prabhu. Wonderful videos. Thank you.